background experiences are in critical care and emergency nursing, basically in community hospitals. I became, in community hospitals, I also did cardiac rehabilitation, and I did disease management programs. And then I practiced as a cardiology provider for about 8 years. I've been a faculty member since 2011. And my research interests are in the important role that nutrition plays in preventing and reducing cardiovascular disease. That's a little bit about me. Tim asked me to be here today just to share with you some of the things that I did when I was blessed and honored enough to meet up with Tim and Don. We had a university-wide initiative called Ignite, where it's an attempt to bring researchers together. And so just in a very informal way, we met up and sat down and talked about what we were doing, and we came up with some ideas. We submitted a proposal. It didn't get funded. And we said, you know what, this is a really good proposal. Let's figure out a way to make it work. And we did. And so that's what I'm going to share with you a little bit about. But he also asked me to talk a little bit about public health. And so what I know about public health is chronic disease is rampant. And chronic disease is things like high blood pressure, heart disease, arthritis, cancer, COPD, diabetes. Unfortunately, 1 of every 2 adults in Kentucky has at least one chronic disease. In the United States, 6 in 10 adults have at least one chronic disease, and 4 in 10 have 2 or more. So chronic disease is an issue, and it's the leading cause of our healthcare cost. I mean, it's just exorbitant of what we spend on dealing with this chronic disease problem. In Kentucky, this is a snapshot of one of the ways that we capture some metrics about chronic disease. We look at the behaviors that lead to those chronic disease or those risk factors. And this is called the BRFA survey. And just as a real quick thing, you can see that adults who have diabetes in Kentucky is at a 13.2% average compared to the United States, which has diabetes at 10.7%. So Kentucky kind of leads the way in several of these risk behaviors. And this is just one metric that we capture here in Kentucky. Another thing about cardiovascular disease, which is the one that I'm most interested in, is a chronic disease. It's the leading cause of death across the whole United States. Despite all these new treatments and all these new drugs and all this new invasive things to treat heart disease, it's still prevalent. Kentucky leads the nation in that prevalence. We also lead the nation in individual risk factors and multiple risk factors. And this is a BRFA survey that just shows you that Kentucky unfortunately outpaces the Americans in lots of those individual risk factors, which is not a good thing for Kentuckians. I do believe that West Virginia has beat us to the point on a couple of these, if not more. So kudos to West Virginia for beating Kentucky on that, and we'll take that. We'll take that. Another little looking at heart disease a little bit more specifically. This is the heart disease death rate, age adjusted, and this is looking at it by counties. And so, unfortunately, the counties in the darkest red have the highest disease rate, or death rate, I'm sorry. And those counties are in our Appalachian region in eastern Kentucky and in our Delta region in the western part of the state. And those are our most vulnerable populations. So a lot of our interest and our focus has been on what we can do to help those folks, those vulnerable ones in those regions. But unfortunately, the whole state of Kentucky is at risk. And so while we do focus on the vulnerable populations, at least I like to focus on the vulnerable, I also recognize that the whole state can benefit from anything that we do to reduce chronic disease.
So Martha, just back on that, just a quick answer. So when it says the rate for the United States 164 would be basically the rest of the United States is this light.
Correct.
Just straight up, all right?
Yeah.
Not good.
Yeah, our heat maps are not pretty. No. And that, yeah, not pretty.
Are there any geographical features? I mean, like I'm thinking geographical as in, are there like major oil refineries also in these areas that like count now?
No, 90.
Coal.
Coal,
Yeah.
but most of them are shut down.
Yeah.
I mean,
But
historically it would be coal, but primarily it's socioeconomic. Yeah.
Patches the coal industry.
Yeah. So if we look at agencies that are trying to improve, we have one such group that has a target to improve the health of Kentuckians, and it's the Kentucky Heart Disease and Stroke Prevention Task Force, which comes out of our Kentucky Public Health Department. And again, they're looking at targeting healthcare systems, providers, work sites, schools, communities, and disparate populations. So to me, the CSA would go right along with what we're doing in the community for what this task force here is trying to work on to improve the health of Kentucky and the United States, but specifically Kentucky. We also have our USDA that has guidelines for Americans about what we should be eating. Dawn talked about that real briefly, but the DGA, those are updated every 5 years, so it's the dietary guidelines for Americans. And so for the 2025, it's make every bite count. And the focus is making sure that people are getting that good variety. And the keywords for these 5 years are make every bite count, but it's about a healthy pattern. So what is a healthy pattern? So a healthy pattern is, let me jump ahead here. A healthy pattern includes the vegetables of all types. So the dark green, the reds, the orange, and then fruit, especially the whole fruit. These are the key components. Grains, dairy, proteins, and oils. But I like that the top two comments there are the fruits and vegetables. And so those are the ones that are really important. So as a researcher, as a nurse scientist, I have to think about, okay, what does this mean in the big scope of things? How am I going to take my practice, my nursing experience, my desire to reduce cardiovascular heart disease, my desire to improve health, how can I do that? Well, then I look to see who's funding that, which is what we started this conversation on earlier, who's funding it. So I look at NIH, and NIH has a strategic plan for nutrition research. And their focus for 2020, 2030, it's hard to say those because we're saying it's 2020. But anyway, it's looking specifically at innovation. Excuse me, what do we eat and how does it affect us? What and when should we eat? How does what we eat promote health across our lifespan? And how can we improve the use of food as medicine? So it's a little bit of precision nutrition, but it's also looking at some other components that they're going to be funding. It's going to be part of their strategic plan. So that's what I've looked at for my funding. Specifically though, when we got ready to do the CSA, when we talked about the CSA, we came up with, we had two studies. The first one I said was the one that Tim and Dawn and I just had sit down and came up, brainstormed, and then tried to figure out where we were going to get money from. And we just took it from different pots. We got it together, and that was called the biometric of CSA participants. That was a biometric measurements. And then I was very fortunate to do a second one where I focused on the nutritional assessment of CSA participants. And I'm going to share with you both of those. The objective of this biometric was to examine the impact of the voucher program on cardiovascular health using biometric measurements from shareholders and household members to assess the quantity and variety of vegetables consumed. We completed that in 2019. I've presented that to the American Heart Association, and that manuscript has been submitted. It's also been rejected a couple of times. But anyway, the nutrition one, the objective was to determine the nutrition status and look at the patterns. But then also, excuse me, that occurred during COVID. So we pivoted really quickly and put in a COVID survey to get some information about how the pandemic affected what they were doing in CSA. That one was completed in October. That's been published, and there's a second manuscript underway. So the biometric, what our measurements were blood pressure, lipid levels, and then the non-invasive dermal carotenoid levels using the Vegimeter that Dawn mentioned. The vegetable intake was collected, and this time using the 6-item Burfus questionnaire, so it was really easy questionnaire. And we did these pre and post. And then we did this, we specifically looked at those that had been incentivized through the employer incentivized through the voucher program. We also included family members if they wanted their family members. And that was a little bit different, but I had never done kids before. And so we stick fingers because we were doing cholesterol levels. And that was pretty interesting. We had one kid pass out. But it worked out okay. Worked out all right. So this is the data that I presented to the American Heart Association, and this is the study. So again, our objective was to see the effect of participation in the voucher program on risk factors. And so we were looking, the things that we know is that eating a diet that's high in vegetables translates to lower risk for cardiovascular disease. We know that only 10% or less of Americans consume the recommended amount. And then we know that community-supported agriculture supports not only local farmers, but also promotes the increased consumption of vegetables. So those are our known facts for this study. Our methods and materials that we used was the participants that were in the voucher program, the blood pressure, the lipid levels, which were cholesterol levels that we did with a finger stick, and then the Vegimeter, and then the intake by the 6-item questionnaire, and then those are the statistics that we used, just some basic descriptives. And the Vegimeter, as Dawn showed you, is like a little pulse oximeter. So it reads the amount of carotenoids that are in the skin, and that's based on basically a month's intake. So it's not what did you eat today, it's what have you eaten in the past month. So it's a really good reflection. The average number for Americans is about 200. And so for this study, I think the numbers that we got were about close to 300 was the average number. And it did become very competitive. We had family members that were in it and they were coming like, I was 250 last time, what were you today? I was 600, oh wow. So, and even among even outside family members, they were competitive because they were there together. So it's a really easy instrument to use because it's pack and go. These are the results. So we had 85 that did the pre-program biometrics and 52 of them did post-program. So small numbers, but these were 42-year-old females, predominantly Caucasian, majority were married. They are very healthy individuals. They had a body mass index of 27 on average. Their carotenoids levels were 286 plus or minus 110. And their Framingham risk score, which is a cardiovascular risk score indicator, was very low. So this was a very homogeneous, healthy, young, white group of women that were in this study. We did not find any statistical significance between the level of their carotenoids and their Framingham risk. It was in the right way, but it was not statistically significant. What we did find was that systolic blood pressure was significantly reduced from pre to post, went from 125 milligrams of mercury down to 120. And self-reported intake of vegetables, the red and orange, also significantly went down. Went up. Also dark green went up, but just not statistically significant. So diastolic pressure didn't really change. Creatinine levels did go up. Just when small numbers like this, it's hard to get the statistical significance, but those two were important for us to follow through on biometrics. And this was just the percentage of change. These were all statistically significant, looking at post compared to pre. So in conclusion from that small study, we said our data identified that participants in an employee incentivized program can effectively reduce systolic blood pressure and increase vegetable intake, thereby reducing cardiovascular risk factors. The second study that we did, again, was due to start May 2020 and was going to be this fabulous study.
What could happen?
What could have happened? What could happen? You can see how our numbers kind of dwindled. We started out with 214 and we ended up with 83 that completed the COVID-19 section, but we still got good data. We used a food frequency questionnaire that was electronic because I had to pivot the whole thing to electronic. There was obviously no face-to-face. But it still actually worked out as good touch points because once a month I was sending them a survey of some type. In July, we asked them about their shares and what they were doing with their shares. In June, we asked them about their shares. In July, we asked about their practices and their preferred vegetables. August, we asked them questions about physical activity. And then we completed the surveys in October. So the next few slides are some of that raw data that we collected in those extra surveys. So this is the question about how are you incorporating your fresh vegetables into your daily meals? Are you sharing them, freezing them, preserving them, or I'm not using them? And you can see the majority of them said they're incorporating it into their daily meals. This was an N of 99. There were 8 of them missing. And again, this is just raw data that I pulled off of a red cap. But I just wanted to share it with you because if you're interested in CSA, these data are probably important to you. This was about how did COVID influence your decision to participate? And it didn't. There was no influence of COVID to participate in CSA because we looked at security, food security. How have you felt safe picking up your CSA share each week in relation to COVID-19? The majority out of 110 said yes. And this one, what is your preference for the method of picking up? So during COVID, they had to prefer the market style, which allowed me to see the produce and make choices. They had the pickup style, which you kind of just drove by and someone handed it to you. And then the third one was a you-pick method, which allowed me to pick my own vegetables, use my own containers. So the majority preferred that drive-through, pick it up and move on. And these were what were your favorites and what were your least favorites. So the favorites were lettuce, potatoes, tomatoes, and cucumbers. And the least favorites were kohlrabi, radish, turnip, and shallot.
That's so heartbreaking.
That tells me they don't know how to
That's just not 110 people. And then I asked them about, do they participate in any of the other CSA activities, the newsletter, the blog, the recipes, the farm updates, and the storage tips, storage and cooking tips. And the newsletter and the farm updates seem to be the most popular. And this was a physical activity. So the first question is about vigorous activity. And you can see these are pretty healthy individuals, majority of them, and then 3 times a week. So, and this was moderate intensity exercise, majority were 3 times a week. And then for low intensity, it was daily, was the most common. So I took that COVID-19 questionnaire that was pretty long, and I was surprised that we got so many people doing it as we did, but we were able to get that published fairly quickly. And that whole part was that the pandemic was challenging food security. And so the purpose was to look at that food security status, the eating patterns, and any perceived barriers that they felt they had about food choices. And so of the 209 participants, 84% were identified as food secure. So we had a really small number, 33, that were food insecure. Both groups, both the secure and the insecure, reported changes to eating patterns during that time period, basically by consuming unhealthy foods. Okay. So that was what we found out about the pandemic during that time frame. So here's a little bit of what I put together. Is research has demonstrated clearly through multiple studies, not just mine, multiple studies that workplace wellness programs can be really helpful in helping employees' health, in improving productivity, improving retention. So I'm glad that UK is continuing the CSA program. The UK supported agriculture project is part of the agriculture department and the horticulture still, is that, sometimes I don't, okay.
Yeah.
Okay, it's an integral component to our undergraduate curriculum and I think our graduate curriculum as well. All the faculty, staff, and students are in the community are invited to sign up for the CSA. So to me, it was like, boom, workplace wellness and chronic disease management really goes together well. So I really hope to take this then into the next steps, which for me would be to compare CSA participants to non-CSA participants. So I really need a good comparison group to say that this is a lot of the difference here. I'd really like to remeasure the biometrics in a larger sample and across multiple sites. So if you all want to get in on the next study, hopefully we can have funding. We can include Michigan and West Virginia in our next site, our next study. And then also like to do some longitudinal measurement for the long-term enrollment benefit, because one of the questions that we asked was, is this your first year in CSA or is this your second or third year? And you see some longevity in that response. So I think it'd be really nice to see the long-term benefits, which would require a longitudinal study. And by doing those, by getting to those next steps, I'm going to be meeting a couple of those initiatives from the NIH's strategic plan, specifically number 2 and number 3 there. So those are my goals. Thank you for listening, and I'm open to any questions that you have.